situation there. And I invite the next panel, Dr. Sumeet Agrawal, Dr. Joyeeta Basu, and Dr. Shashidhar and Dr. Vipul Rastogi. They are all here. Please join us. And I think instead of running the slides, because that then you can't see the pictures, let them all introduce themselves, if that is okay. So we'll start with the yes. So the mics are there, and we would start the introduction with you, Joyeeta.
This one? Hello?
Let's begin. Joyeeta, please, your introduction in your words.
Okay, my name is Dr. Joyeeta Basu. I'm co-founder of Doctors Hub, which is a multi-speciality clinic in Gurgaon. And I've done my undergrad from Lady Harding Medical College, and I've done a DNB in general medicine, in family medicine.
My name is Shashidhar. I work as a ENT consultant with Artemis. My areas of interest are pediatric ENT, and I'm also into integrative medicine with Ayurveda in ENT otherwise. And I love running, and my hobbies are ultra marathon, and that's pretty much.
I'm Dr. Sumeet Agrawal, and I work as a consultant in rheumatology and clinical immunology at Artemis Hospital. And I do not have great hobbies, especially the crazy ones like Shashidhar has. But I'm very passionate about my job, and I basically deal with lots of musculoskeletal pains and autoimmune disorders.
So I'm Dr. Vipul Rastogi. I'm a consultant psychiatrist at Medanta Hospital, Gurgaon. I like to talk about mental health, preventive mental health, and I wish everybody a very good mental health. I love running, cycling, and like writing. So you may see me on television, and you might read a book or two from me. So, but happy to be here.
Okay, so we start the session by I think we can start with you, Dr. Sumeet.
Why not?
So as you said, you deal with a lot of musculoskeletal disorder, being a rheumatologist. And one of the things which we realize in medicine today is we can easily treat what we measure, and it's easy to follow them. But you deal with a lot of immeasurable thing, which is pain. And people coming with chronic pain, we all know it's sometimes so difficult. How do you place that in your, maybe some examples of how to measure this invisible, immeasurable symptom, which is one of the most common presenting symptom in most clinics?
So Dr. Bina, absolutely, pain is one of the most common reasons why people go to a doctor. And ironically, it is also something which is most poorly understood. And therefore also one of the most difficult conditions to assess, judge, and manage. We in medical practice actually tend to focus a lot on, that what is a normal blood sugar, and when you start chasing a patient with diabetes, what targets to achieve and what targets to look forward to with treatment. But unfortunately, pain, despite being a very common problem, is completely unmeasurable. And one of the reason basically which I feel is the reason behind this complexity is there are lots of factors that influence pain.
Job of physician is taken as to get rid of pain, but I've changed that approach few years back, especially when working with kids. Parents tell pain, they have this reaction, pain is a bad thing. But if you change the perception that pain is the one which gives you gains, and when you exercise, when you run, you have to go through pain, and a good pain and a bad pain, they should be able to differentiate. Something which can keep the progressing would be a pain which would be like their friend, and they'll be proud that they endured that pain. Whereas the pain which they are suffering, mostly because of thoughts and unnecessary stress in the mind of anticipating some issues, I tend to tell them it's a bad pain, and they can psychologically get rid of them. So more than the pain, our perception to the pain, and when we emphasize that, that can make a huge difference in the outcome. That's my change.
Yeah. So the thing with pain is incredibly subjective. So, and it is if you have two people who have the same injuries, one person might have a higher perception of pain, the other person might have a lower perception of pain. A person who is in a more positive frame of mind will always have a lesser perception of pain. So it is very, very hard to quantify it, and sometimes very hard to treat it also. If you look at it from a perspective of a patient who's come with some pain in their body, they're very confused which doctor to go to. So should they go to a pain specialist? Should they go to an orthopedic? Should they go to a physician? Should they go to a rheumatologist? So it is very confusing times for the patient. But for any chronic sort of illnesses, pains, I think a multidisciplinary approach is very important, and these days important. So rather than prescribing just medicines over medicines, I think it is about understanding why it has become enhanced of us. It's incredibly hard, very, very hard to treat. But if we just focus pain, then it is not going to give us a good outcome. But also looking at the reasons for what precipitates it, what triggers it off patient.
So basically, I completely agree with what Shashidhar said. If you associate, becomes more tolerable. If you train your brain in a way that if you live through this pain, probably you'll enjoy life more, and you tend to. So it is a very subjective feeling, and it a lot to a lot extent it depends upon the state of your mind.
I think that is, yeah, please,
I'm
Joyeeta.
going to add a few things over here. As a GP, I usually see a patient coming in first with the pain, and when they find no relief from me, the specialist is coming in most of the time, at least in Gurgaon. This is what I see, number one. Number two, and like you said, it could be subjective, and it could be because of more reactionary pain to some injury or something like that. And whenever we talk about pain, I don't want to categorize into elderly and younger people and male and female, because in these four categories I find there's a vast difference between the pain. Well, if you talk about the pain scale, whenever you do the pain scale, I find a vast difference in that. And sometimes I just want to throw away the pain scale, because like you said, it's subjective. Some people whose score of pain would be really, really high don't really have that much of a pain. It's very, very subjective to this. The second thing, emotion plays a very big role in what their level of pain is. If they're emotionally in a good state of mind, in a stable state of mind, the pain ratio is usually, the pain scale will be always less than 5. If emotionally they're a little high strung or a little unhappy, the pain scale is on a higher level. So it depends on how, like you rightly said, on the subjective. It's very subjective and very this, and we have to take that extra 5 minutes finding out exactly how much of a pain medication is needed and how much of counseling is needed to treat that.
I mean, the thing to think about is when a patient comes and we are doing some procedure or anything, and they all ask the same thing: will it be painful? And you're always in a fix if you test disturbing. for the patient, and if you don't tell it and everything. So I'm just curious, how do you deal with that situation when a patient says, okay, doc, you're going to do this, will it be painful? What's your response on that?
With LA and they start doing the check. And it's sometimes not effective by then, and the patient experiences pain, and that is a very bad experience. Sometimes people come to us that he had, and recently I had a patient and who had been put on Tugler outside, and he was not ready to get it. Then that got infected. We had to remove it, and then we advise not ready because he had so much pain last procedure. So probably you have to make sure you have to tell him a little that initially with the small needle there would be some pain, and then after that there would be little or no pain. So that is what maybe you can do.
So basically, it is good to prepare them for the pain rather than telling them that there won't be any pain. So that would actually change their threshold to handling that pain. And people, in your opinion, how does psychology basically affect
person is very stressed out, then they're going to have much higher perception of pain. Now, has been in plaster, it opens up after 4 or 5 weeks. The hand is weak when the plaster is cut. Everybody tells them, okay, exercise, move your hand, but it hurts when you move it after such a long time. And the patient will come and say to the doctor that, look, first get rid of the pain, and then I will move my hand. The doctors will say, first move your hand, and then the pain will go away. So it is very difficult, right? So you have to prepare, you have to counsel, you have to prepare, you have to suggest from beginning that, look, if you move it in a period of 3 days, 4 days, or 5 days, it will go away. Maybe you need to, if somebody is very anxious, you need to make them speak to somebody who's been through this before. And with the communities, things that they're not comfortable with, or their fears, or because if somebody's broken their arm, they might fear that they will not be able to use it again. Or if somebody has been a weightlifter, whether they'll ever be able to pick up the weights again or not. What also happens with people is if you do not prepare them enough. So let's say Dr. Shashi is an ultra marathon. Next day, the plaster opens, and if you don't prepare the person, they want to run 10 kilometers. So it's just going to get injured again. So you prepare people from beginning that, look, this is going to be the timeline, so that 500 meters the day after, and that's how you progress. So I think a good pain management always needs somebody from the mental health side, not just to give a counsel or, do some activity, but just allowing the patient to speak or just express what they're feeling and their thoughts. And that makes a huge difference.
So this session is mostly focusing on these small issues because I think it's a good idea to start with small examples because similar kind of counseling needs to be done for many different conditions, with pain being such a common presentation. Another common but difficult communication which we have with patients is breaking bad news. And Dr. Vipul, I think one of us has had to, at some point in time, do this thing called breaking bad news, and I would like to hear from all of you. So, Dr. Vipul.
So, breaking bad news is something that we all do, but something that is not taught to us. We just learn it on the job. We see our seniors doing it, and we learn it for good or bad. I trained in England, and when you're a foreign medical graduate, there were procedures that you're meant to do. It's a set of 10 or 12 procedures that you need to do. One of the stations in that is breaking you fail the test. So that is how important breaking bad news is. Now, what is a bad news? Traditionally, we all feel that it is, telling, if I tell somebody that, look, you have dementia, or you have psychosis, or you have Parkinson's, and over a period of 5, 10 years, you might not be able to do what you're doing now. Or in your profession, somebody who has type 1 diabetes, a young child, CKD, or a rheumatoid arthritis, they're all bad news, because the person's life is going to change. And unfortunately, I don't think we are all very good with it. We just say, okay, you have this is done. We always have to give hope to the patient. We also have to tell them that this is what it is, this is how it is for you, and we'll try and keep it as best as we can, and keep you as comfortable as you can. So that breaking bad news, the first appointment, when you tell the patient that this has happened, this is the diagnosis, and this is the journey as they progress through their illness. But a job poorly done in the beginning can make the person very distressed. And a job poorly done in the beginning can make the person very distressed. And in a way, absolutely needs to be managed, a skill that needs to be taught with patience, commitment, time. And as far as doctors are concerned, sometimes they also have their apprehension. They don't want to tell the bad news. And not prepared, because you don't want to have said, acha dekha jayega, kya hota hai, dekhenge. But you're the person who's going to tell that, look, this is the life changing diagnosis that you have. So as I said, a skill very, very important, difficult to learn, and difficult to master. And it is about doing things as best as you can, because there's no perfect way of doing it.
if you're seeing a patient who is likely to have to hear this from you, and if you think that that person is not mentally prepared to handle that kind of news, would you want to go gradual, or in a few sessions or a few settings more, and gradually tell them about that bad news? Or would you believe that
But you have to go patient by patient. You can't have one thing for everybody here. I think what is most as a doctor time on that job, it is important to have a good rapport. You talk patient knows what their knowledge and information is up till now. They have had the test report in their hand for 2 days. They might, what does that mean? They might have discussed it with their family or something there. So it's about first, they might not know anything. You can ask them that, look, do you want to have somebody with you? And you might give the information in bits, you might give it together, and it depends on the person's mental state, how much you feel as a doctor they're able to take that day. But just ignoring it, or just passing it for the next day or the next day, that does not help, because the patient, I think, has a right to know. We've seen people who have gone through surgeries, cancer therapies, radiotherapy, chemotherapy, and they don't even know what has happened to them. And that I'm talking about, in some of the bigger hospitals that I worked, because the family members have said, don't tell. But that's not how it should be.
So there are two very, very difficult, and there's a kidney failure, and everyone is afraid of that. So these two, so that you can make rapport, you treat him, he gets like, and then you gradually well, you will see. Also take, there are family members, they say that we don't want to tell him, but I tell them no, it's important. Then he knows he's undergoing that So not telling him is not going to help him. Certainly, maybe a child, and whether he's prepared. So initially, I will maybe send him outside and then counsel his family and then tell them to do it. So means still it's not a singular thing. It's very we gradually learn over a period of time.
Yeah, not good.
You know you take a name unless they might take it or you tell him no, this is not. I'm not me. I tell you my personal experience. One
Is own up, say we can't predict which will happen, what will happen. Again, surgery is different, and from my point of view, I'm not going to say I made a mistake. This is what worked, but yes, this has gone wrong in your case, and we'll try and change the medication. Take that softer approach. The moment you say % of your problem is solved, most people are not out there to get you. They're not out there to abuse you or anything. There will be 0.1% of the population who will, no matter what you do, will find fault, and that you can't do anything about. And I don't think you should even berate yourself about that. As long as the rest of the part and you have been sincere, I think the patients also see through the fact that you've been sincere. Second thing, when you say breaking bad news, I had a patient, which was a personal experience about a couple of years ago, where this old lady came and said, every time that I come to you, जब भी मैं आपके पास आती हूँ, आप हमेशा मुझे कुछ ना कुछ सर्जरी के लिए भेजते हो. And that's a job. That's the job. आपको प्रॉब्लम हुआ, मैंने अल्ट्रासाउंड किया, कुछ निकला, आपको सर्जरी करना पड़ा. You were fine after that. You came back again because that thing recurred. So it threw me back a bit, because in my first mind, like he said, I was defensive. I mean, I'm not at fault here. I helped find the problem. But then you have to think from her point of view. And again, you soften the blow, you soften and you say, I agree, but you had a problem and we found it. And now once we treat it, you will be better again. Unfortunately, this has happened. But I don't know how the elderly who are not very good, they thankfully don't look at Google, so makes my job a little easier. But yes, it does throw you when they say, "Abhi, jab bhi aapke paas aate, aap kuch na kuch gadbad nikalte ho, meri surgery hoti hai." What do you do?
The problem is that every possible complication or side effect of a drug or a treatment cannot be talked about. It is just not possible, because that would take away the faith in treatment. So you have, as a doctor, you have to understand that there are patients who might end up developing the rarest of the rare complication, and you have not even thought about that in
Absolutely.
your, in the darkest
We are
of your,
human beings. We can't have read about
communication is, and you have to tell them that there can be unexpected side effects as well. So communication is extremely important, no doubt.
So regarding breaking bad news, so this problem is particularly prevalent in our part of the world, where you also want to, and the family also wants that the bad news should be broken to the family members rather than the patient. So this is not there in the West. When you talk about breaking bad news in West, it means directly to the patient upfront. But here, everyone expects the patient should be out of the room. First, you talk to the family, then you talk to the patient, and in many cases, like you said, patient wouldn't even know that he's suffering from cancer. The family members, everyone would know. They would know that after 3 months he's not going to live. But the poor patient, he wouldn't know. He wouldn't know. He would have had so many jobs to complete before he had to die. So he wouldn't have that chance. So what do you say about that? What should be the, standard, whether it has to be to the family or to the patient? Because family members get very upset if you tell it directly to the patient in our part of the world.
So, I mean, if you look at the medical ethics, then it's not right. Right? The patient has a right to know. Right? If you're giving him chemotherapy, he needs to know what is happening. If you're sending him for a surgery or radiotherapy, he needs to know. So that is now not how it should be. You may choose So let's say somebody who does not have capacity to understand it, then you can justify not telling the patient, but otherwise the patient has a right to know. I think there's no other way of saying this.
But I think, the court also says that the patient has the right, and you as a doctor have the responsibility to tell it to the patient. You have to.
Actually, this was the issue came from the ethical point of view. When HIV became a problem in our ethics, we practice ethics as we learn it from the Western standards of ethics, and this is the practice in the West that you tell the patient. Whereas here, it's like you don't tell the patient, you tell everybody else. In HIV, it was a real problem. And in fact, ICMR at that point in time, maybe somewhere in the mid 90s, early 90s.
To come back and ask you a question if they want any clarity, give them your email, and always send a person out with hope. Don't send them out in despair. Less for most of the part. We'll monitor your kidney function and all that. So that is the kind of hope I'm talking about. We're not going to say that you will not need
But
treatment.
I think the flip side of this entire giving hope and telling them the reality is that they might end up just switching the doctor and end up with a totally wrong treatment.
That might be. So again, if they switch the doctor, so first thing is, I think you should not initially, when you are starting your practice, then you have this tendency that you have probably limited number of patients.
No, it is not in sense of that. Not in sense of that. For you, for that particular patient, you might actually be the best doctor, but they are missing that opportunity because of.
No. In any case, he might switch the doctor. So that fear should not be the reason for not telling him the right thing. So nowadays, because if we know, if I don't tell this patient the right thing, the right diagnosis, the right treatment, he is going to suffer. Whether he, and I tell you with this, 90% patient, 80 to 90% patient, they come back. Even they go back somewhere, they will come, they will find whatever I was telling it was truth, and they will come back. And because this is for the good of the patient, if I don't tell the right thing on the time, probably he will miss the treatment, he will not understand it, and then later on he might end up in the complication, like as I said, for the need of dialysis. At some point of time, patient needs a dialysis. If I don't tell the patient that at the right time that he needs dialysis, and he lands up in the complication, then what happens? Then you are responsible for the not giving the news at the right time and the right.
The important question is the honesty, because when the patient comes to you, he comes with a mind that you know what is wrong with him. And as often the case is, 90% of time, the diagnosis is evolving. With the new symptoms and treatment response, your diagnosis changes. And what you say a week back might entirely change with the reports or whatever comes in this. How often should we be honest to tell, hey, I have no clue what is wrong with you, but I'm just trying to find out, and there's a process of finding out your diagnosis, but you need to give me time and uh, be patient with me so that we can find out what's wrong with you. And this approach comes with maturity, that you're not afraid of losing your patience. The first part which you're saying is because when you're in your younger days, you're hot shot, people come, you write some medicine, he gets a relief, and there's a thrill, oh, you got it all right. But then you realize it doesn't happen every single time. And there are difficult, as long as you're honest, they stick with you in a very with you because you're sincere and honest with them and you really care for them. And those are the patients, when they improve, I think it gives your life a sense of purpose, that okay, I am this doctor who really fixed this guy who who could not get relief from X number of people, and finally he came to me. On the other hand, I had one patient who just came. He had 18 surgeries for larynx. हमारा पहला surgery ठीक नहीं हुआ इससे पहले वाला, and he went berserk. इस डॉक्टर के पास भी गया, उसने बोला तुमसे पहले वाले सर्जन ने telling him that the one of the brightest of all. Show him videos and other things. Look, okay, that there's something can be done. So push to the patient is extremely important, and we have easy to get prejudice when the patient comes that a lot of his symptoms are psychological or this or that. You have to listen to the whole process and have your own process of evaluating them and not getting biased by your time or your mood or any of those things. Very objective.
So for you, whatever he wants to do
Yeah,
at
agree.
any level.
Agree.
So maybe that's a hope.
Yeah, so for type 1, because nothing else works, nothing else has worked for me. Not giving examples in the clinic, the only I connect them to the support group, which I do every month. That's the only way. They have to listen it from other people who have it. Coming from me, I may be giving example of Wasim Akram or whatever, which I always do. It's become like I am bored of that example because that doesn't work. They do not connect with that famous personality. It's not always like, it's very different for very. So one guy who is a big fan of Wasim Akram and he keeps watching YouTube videos and runs, and he has been managing type 1. But it's so different for every kid. A small girl may not be impressed by a famous personality. So I do not know an easy answer to that, and I'll move away from this. But I think taking from Shashi, I would say what he is saying is accepting our own humanity, being very humble about the uncertainties of what we understand. As soon as we become that and leave that arrogance of that initial years, which we all have sitting on that seat, things become much easier. When you show your humanity, show your errors openly, I think it simplifies it a little bit there. Should we take up the third part of it, which is very important? And I would ask Joyeeta to answer that, start the discussion, and of course, Shashi and Sumeet and Vipul to join in, which is healthcare is no more just restricted.
Many of the things, especially with COVID, many things are first announced on the social media. It was not even peer reviewed in many of the journals, but it was announced on social media. And that's how people got to know and started thinking about it. So there are many things on social media where there's misinformation, there is trolling, there is people who are giving out their own fact-finding missions. There's a lot of things happening over there. So how to dispel or debunk myths on social media is what Veena asked me. And there's no easy to do debunk myths on social media because people have already started off. There are lots of things starting with WhatsApp University where people have already a lot of things that this is going to be the answer, this is going to be the treatment, and they've already made up their minds. So there are many ways to debunk the myths. One people say is to instead of debunking, to do something known as pre-bunking. You but most of the people are there to hear you out, to listen what you have to say, and if you've communicated it effectively and communicated with evidence based papers over there and you put it out over there, people are there to listen to you. Second thing that I have seen happening on social media is people are very fond of taking one another down, and that happens very frequently with our community also, the physician community or the medical community. And we need to stand up for each other. We need to I won't say use the word protect, but I think we need to stand up for each other. We need to help each other out in these kind of conditions. We can't be going about contradicting each other on social media. We have a problem, maybe you can DM a person, or maybe you can tell another person, or maybe you can have a discussion over there, but don't outright one doctor to another, don't outright go over there and try and bring him down. You can have a discussion. There is a way to have a discussion over there. You can discuss it that maybe this is you have said this, maybe this, but maybe this, I have this point of view, and maybe we should be talking about both points of view and come to a point where everything is uh, where we can have a better approach and better way to deal with this situation. You have something to say?
I think the biggest tragedy or the drawback doctors have is they cannot openly talk about the treatments because the MCI kind of prohibits us to put patient testimonies and anything which is related to endorsement that this treatment works vehemently with your name on the internet. So India TV, there's Ramdev ji and liver ka to cirrhosis मैंने ये देख के ठीक कर दिया and Dr. Kaushal is हुआ. But we are at the biggest or other things on the internet. Do my digital marketing course just because I was so frustrated that even if I do a simple search treatment of chronic sinusitis, everything is there when the reader reads and none of them is true. The top 10 searches you see is entirely different, which are motivated by greed and by marketing, by some vague treatments or pushing the patient towards themselves. And those people who have really done a good job, they're nowhere to be seen in the internet search. So until we start up and take the honors that, I'm running a clinic, let me have my patient information portal where you are having your own Instagram handle, Facebook handle, and YouTube videos about every little thing which we say to the patient. So if I made a list about the things which were there, it was only 97 topics over the last 1 year, which the patients were asking me again and again. So all I had to do was to discuss those 97 things. चावल नहीं खाना चाहिए, ये नहीं खाना चाहिए, जुकाम खांसी में क्या खाना चाहिए, and that's a 5 minutes, 10 minutes thing, and you put it over this, and you don't have time. You can just tell the patient, ये देखो ये QR code है, यहाँ scan करो और देख लो, and they're very happy to do it. So until we all take up the honors of dispelling these myths, we are going to be crowded with BCTs coming in with more internet reach and everything, and we all have to be computer literates, and we have to do the internet marketing and other things in our own hands and be more aggressive about it rather than just leave it to the social media to play its own part. That's one thing. So Nikhil is the youngest guy who's started his own channel on Doc Talks, and all he does is picks up one topic and keeps on going, and that's the same inspiring story.
Me and motivated me to start that. And yes, on social media being put by people who have no connection to medicine, and they have the liberty to say anything, and their titles of the videos or the posts are so dramatic that people get attracted and people start believing them so much. So the only solution I think is we have to do that part to provide the correct information, even if we don't criticize them. But at least when we are providing the correct information, people will start coming to know about the realities.
That's our job, entirely our job.
I'm not an expert on this. I think people should be able to add more.
So I think that's very true that, the top hits are usually always controversial things. And what people don't realize is that, when you look at research papers, and especially on internet, you can find whatever you are thinking to be true. So you will find absolutely everything that you have in mind. There will be something that proves your theory true. So you will have, as Joyeeta was saying, you will have papers for mask, you'll have papers for no mask. If I'm somebody who is anti-mask, then I will find my paper and show it to everybody. Look, there's a paper which says masks are not necessary. So what I do in my practice is I usually give them a couple of websites that I think they should go and read themselves, which give a balanced view. There is no point giving a website which says medicine ka koi side effect nahi hai. So, but if you give them a website which gives this is the medicine, this is what it is for, these are the chances of having side effects. And I think that's how I go around, bypassing that part where people come and say, okay, I've read this on Google. Why did you not tell me this? So otherwise, the option is that, you go the American way where every medicine you prescribe, give them a 10-page, a brochure about the particular medicine. But it is a big problem, and I think something that we have to preempt it, because everybody, we have to assume, knows quite a lot. And also, most of the people will go and search for things even before they come to you, or even after they have seen you. And personally, I always make sure that I write the diagnosis of the patient as well on the prescriptions each time, so that if they want to read or understand, then they can. But I always give them a couple of websites there where they can go and get more information rather than just scrolling, or scrolling through the internet, finding answers.
About extended minds, that not all the thinking and all the processes are happening just here, and people around us, instruments around us, tools around us, these are all extended mind and extended tools. I think we should not shy away from using
extended tools,
things. Not everything is handled by your own minds. I think anyone wants to add something.
I think Shashi has put it very appropriately how the internet works. And I'm a plastic surgeon, so most of the plastic surgeons, especially the newbies, so they post dramatic pictures of patients, and they can do a dramatic change. So patients do get attracted to that. So it's important to communicate with the patient when they come to you. That's the most important thing, and empathize with them, and make them talk to the patients you have treated. So that's the best way to take it.
Which is very difficult or costly, or they are not very sure. Like kidney transplant is one of the things, or dialysis is one of the things. So if you tell, so it's better if you can let them talk to some of your patients who have this experience, and they believe it. Then so nowadays we get, with experience, you understand it, that more and more people come through the patients, and then that is the best way, that you can just tell that, ask him and he will tell you the truth. So because because we all have this tendency, and especially so much faith in doctors and the medical as such is going down. So whatever you say, sometimes patient may not believe it, and then it's better uh, to let them talk
So
to
there was
their
this trust index which lists how much general people trust in all the professions. Doctors in India still have enjoy 89 to 92% trust from people, whereas the journalists and politicians go as less as 16%, and nurses. So we enjoy the on the website, internet, where we are giving an honest review, or whatever our experience is dismal. Any place, if you just read it, it will be with icon, click, subscribe, and then there will be, buy this. And that's where you have to understand, when there is a buy this, it's been put for some monetary gains. But it would be nice if you on all the 5 social media handles, Pinterest, LinkedIn, Facebook, and Instagram, and your Twitter in one go. You have a content. You don't have to go waste time in put at all different sites. But it's just 10 minutes, one picture, one this, and your message goes everywhere. And if all of us start doing it, there will be, quite a good information there for the patients. Social media do's and don'ts.
If I can, simply that it is available on the net. It is still too complicated. You may deal with strata, which is highly a majority of the upper middle class, educated community. I'm non-practicing, old, retired. I've done the translation at the tertiary level to what a lot of people tell the patients, because you communicate, they read the internet, but even that is too difficult. The internet, however, all this thing, videos and all that, it is too complex. And so the level at which you have to communicate, unfortunately, we are fighting a big battle. Every morning it bugs me, Ramdev saying diabetes can be cured. That the whole world, and they have the endorsement.
I think we are all handicapped as a doctor
So
to explain simple things in a very complex way. And I would say a doctor is a genius if he can explain a concept or disease in the simplest form. And that's where we all are handicapped, because we know so much information that we keep on adding tails till the end, till it becomes a whole broth of something which even we don't understand. So if
so
we,
I think what I'm only saying is that if you are thinking in terms of communication, you probably need input of an intermediate layer of somebody who will look at that content. I don't know, whatever it is.
So
Yeah.
interestingly, so I'm a non-practicing surgeon as well. So the non-practicing surgeons have a little more different perspective, right? I work in research. So there's this word that is used for doctors speak. It's called gobbledygook. So when you start speaking, the person's just hearing your words. He's not understanding. And you are speaking so enthusiastically, and it's all just going through his ear. And he's nodding. So he's not understanding. Please realize that. So it's very important. I asked my daughter, she's studying medicine. She's in third year. She's a young doctor. She was talking very simple language. Now in third year, she's suddenly gone technical, right? So she wrote a consent form. And I said, okay, let's just, there are softwares to run the consent form language. So readability softwares. I said, let's do readability software. And at third year MBBS, her readability, and she thought it was very simply written, was of grade level 18. That means 18 years of education and you can read that. So you cannot read it. Her consent form was illegible and ununderstandable to normal people. You need 7th grade language to speak to people. So it is not an easy task for doctors, for sure, but somewhere it has to start.
I think the more important thing is that you have to communicate with the patients in the language and in the way they understand. So you have to relate. So like as a plastic surgeon, I tend to do a lot of kids, with small cuts and all these things. So sometimes I find that you have to become like a child, interact with them at a level that they understand. That what is their hobbies, what do they like, what movies they see, what characters are they're seeing right now. So that way you connect with them. So it goes with all kinds of patients, even for an adult. What are their hobbies? You have to know them a little bit. What do they do? So just to break the ice. So they feel that they're very comfortable with you while they're interacting. And they'll open up and come up with all their things. And they'll come back to you if they have any doubts. But if you create a barrier, then it becomes difficult. That you keep the distance. It's not a bad idea to touch the patient. Just examine the hand. Nakhun nahi kaate for a small kid. For a woman who comes to you, oh, you're wearing a nice sari. What do you do as a hobby? I have had patients who have gifted me paintings after their surgeries, because I just asked them, doctor, I stopped painting, but since you talked to me, I painted this for you. So it's very important to connect at a personal level. You are a doctor, that's all right, but then you are still a human being, and you have to connect to the other human being in a way that they understand you. So that's very important.
Balance also. So it's a little bit non-practice and practice oblique. Yeah, my question. No, so my question is, because what happens is sometimes patients want to become friendly and over friendly with you, right? How do you keep that gap? Is that, yeah, so that's actually going on to our next session. So maybe we can keep this for the next.